Hey Metro Fire, Dr. Mackey. Meeting today with Dr. Quist of the Department of Behavioral Health.
Hi there, I'm Ryan Quist. I'm the Behavioral Health Director for Sacramento County, where we're responsible for all mental health and substance use disorder services for the Medi-Cal population here in the county.
Awesome. Why are we together today? Well, as you may or may not know, there's an assess and refer policy making its way through the county, which will eventually give us the ability to evaluate a patient in the field and send them to a facility other than an emergency department, which, if you've been in EMS long enough, you know that that's a major departure from how California's done it for 50 years. But it's not new to EMS. It's done in other parts of the state and other parts of the country. Today, we want to talk about psychiatric clearance because, as we all know, a lot of the psychiatric patients we evaluate end up in emergency departments, then they may stay there for days. And wouldn't it be amazing if we could just get a carefully selected, properly evaluated psychiatric patient directly to a behavioral health facility where they can initiate treatment for their behavioral health crisis. So that's what we're going to talk about today. There is a clearance algorithm that has made its way through the county, and it's made its way through behavioral health. It's been uniformly agreed upon, and that's what we want to talk about today, to do a little bit of training on that. But I'm going to start with Dr. Quist. Like, why would this be so important? I kind of started to allude to some of it, but why is this so important?
So the main goal is, in order to get them to a psychiatric facility, well, the psychiatric facility doesn't have the right setup to deal with a lot of the physical health care needs of individuals. So our goal is to screen for any physical health care conditions that the psychiatric facility would not be prepared to deal with.
Excellent. And so the idea is here's finding that medical condition that the facility may not be equipped to handle, and therefore we would actually be delaying care in those medical conditions if we went directly to a psychiatric facility. All right. So let's start working through the algorithm a little bit, and you'll see it pop up on the screen for you as we're talking through it. And so the patient enters into our arena usually via one of two sources. It's either a 911 call or an engagement with law enforcement that then engages us. So that's where things enter. But the very first exit point, there's multiple exit points through here which will direct the patient to the emergency department. The first exit point, is there any medical concern requiring attention? And so you can imagine what some of those are. The more the obvious ones are, lacerations that are going to require repair, if there's an overdose that's involved, if the person isn't ambulatory, which is a big thing. So if they have a new onset of not being able to walk for whatever reason, it's a traumatic injury or they just decide that they can't ambulate, that creates some challenges at our facilities. We want that evaluated in emergency department to see, is there a medical reason for that happening? So that's the first exit point. So number one, is there any medical concern that's going to require evaluation or attention in an emergency department? I understand that that's broad. That's difficult. But what I want to reassure you with is that you're not going to be alone in this evaluation. We have other healthcare providers out there, some PAs and nurse practitioners will be working with us that can also guide that assessment as well. So if we make it past no medical complaints, the next stop is violent or combative. So patients that require a lot of physical restraint, you show up on scene and there's multiple people trying to restrain them, probably not the most ideal patient to take directly to a psychiatric facility. Those patients might require medication that we don't carry to calm down the situation and so that they can engage in their treatment and care. And then we come to the S.M.A.R.T clearance, and that's where we're going to spend the bulk of our time because I think that this is going to be a new concept for a lot of the viewers. But Dr. Quist, has S.M.A.R.T been around in Sacramento County for a while?
It actually has been developed, I'm not exactly sure, maybe 2 or 3 years ago, and being used by select groups of folks. We have our community support teams out in the community, our mobile crisis support teams that work with law enforcement, things like that.
Right, and I think I even use it in the emergency department. It's part of what I use in the emergency department that with our behavioral health technicians that make a decision about how extensively medically a person needs to be evaluated. And again, this is kind of picking through the potential medical complications of a patient that would signal that like there's something else going on here. It's not just behavioral health. S.M.A.R.T is an acronym. So it's meant to be smart as well, but it does stand for an acronym, and S is suspected, M is medical, A is abnormal, R is risky presentation, and T is therapeutic drug levels. So let's start with the first one, suspected new onset psychiatric complaints. What would that look like?
So S is suspected new onset psychiatric complaints. This is basically, does the individual have a history of a psychiatric condition? This is a really easy question. Want to keep it sort of neutral so that somebody doesn't feel like maybe they might be judged if they answer it the wrong way. So I would typically ask this question around, have you ever received treatment for any type of mental health challenge?
Perfect, simple. And sometimes the cues will also come from their medications. If they're already on antidepressants, antipsychotic medications, that would be a cue as well.
Yeah.
M, medical conditions that require some sort of screening. So these are going to be the diabetics that have very high blood sugars, and for the S.M.A.R.T clearance, any patient that's a diabetic that has a blood sugar greater than 250 or less than 60 ends up going to the emergency department. They would fail the S.M.A.R.T clearance. And the other one is anyone who's pregnant, right? So patients who are pregnant need to go to emergency departments, and so that they can get extended care for them and their baby as well. So the next one is A for abnormal, and these are all pretty much vital signs. These are the kinds of things we measure on a daily basis in pre-hospital care anyway. So this is a person who has a systolic blood pressure greater than 160, a diastolic blood pressure greater than 100, pulse, bradycardic is you're going to see less often, so less than 50. Greater than 110 is the cutoff there. So if their sustained pulse is greater than 110. So as you can imagine, you're already going through in your head the calls you've been on. You can start to see these patients are going to fall out from this. So this could be a person who is psychotic because of methamphetamine intoxication, right? They're going to have a pretty high sustained pulse. Those patients need to go to the emergency department. So we need to get them evaluated medically and stabilized. So the next one, of course, temperature, greater than 100.4. So what does that mean? Does that mean I'm taking a temperature on somebody who has a behavioral health complaint if they have no medical complaint if I'm doing the S.M.A.R.T clearance? That's 100% true. We want their temperature taken. Even if they have no complaint of fever and they have no infectious disease symptoms. We want to make sure that they are not febrile. Room air saturations, less than 95%, that's a pretty easy one. Respiratory rates, again, less than 8 or greater than 22, another pretty easy one. Glasgow coma score of 14 or less. So every single patient that passes a S.M.A.R.T clearance is going to be 100% coherent, alert, awake, cooperative. So that's very important. So GCS of 15. And then unexpected physical exam finding. While you're doing your physical examination, if you come across something that just kind of doesn't add up, and some of the things that I didn't mention in here that sometimes happens, right? The unexpected physical exam finding can be an infectious disease process as well. It can be scabies. It can be, we don't want to take a patient that has like that to a behavioral health facility. We want them to go to an emergency department and care of. So that kind of covers the long list of A's. And yes, we're going to go through every single one of them for the S.M.A.R.T clearance. And remember, all the way through this, we're looking for exit points. The S.M.A.R.T clearance is designed to increase the safety of taking a patient to a facility that doesn't have the internal capability of addressing medical concerns. That's the whole reason why this is written the way it is. All right, so we've made it through suspected new onset psychiatric complaint. We've made it through medical conditions, abnormal. I'll pass it off to you, Dr. Quist. Let's cover risky presentations.
All right, risky presentations. The first one under risky presentations is their age. If they're under the age of 18 or if they're over the age of 55. These individuals have their special health conditions and special health circumstances that we want to make sure that we get screened for, make sure that the psychiatric condition is not a result of something else. Possible ingestion, if there's any sort of suspicion that they may have taken something that may be causing this. Often you can get to this just simply by asking them if they've been taking any type of medications that they don't normally take. Ask them if they've taken anything recently. That's an important one. That would definitely need physical health care that the psychiatric hospital will not be prepared to take care of. Is there an eating disorder involved? You can get to this around both through conversations with those around them as well as having a conversation with the individual themselves. Potential for alcohol withdrawal. You want to have an idea whether or not they have been drinking over the last while, have a conversation about their alcohol intake, and then watch for other physical symptoms that would be hinting that they may be also experiencing withdrawal at the time. And any other possible appearance of appearing ill. So if you see any other indications that they may have something going on physically, that's something to take a look at.
So possible ingestion, I want to get back to that too. So this could be an accidental or non-accidental overdose.
Correct.
As well. So anything like that, it may not necessarily just be a new medication that they're taking, but it's something that they were never prescribed, never given, and that could be causing what we're seeing.
Absolutely.
Right. And then another thing, I find that the potential for alcohol withdrawal, just a simple question I asked them in the emergency department, I said, have you ever experienced seizures or tremors and shaking because you didn't drink alcohol? And everybody that I've asked that question 100% knows the answer to it. They say, oh yeah, I have had seizures before if I didn't drink, or yeah, I get really, really shaky. And oftentimes I'll be shaking right in front of you.
Right.
The good thing about that is someone who's actually actively withdrawing from alcohol, they're going to fall out in the abnormal vital signs anyway. Most of them will have a fast heart rate. Most of them will be hypertensive. So anyway, so they'll fall out there. Okay, and then that ill-appearing part, right? That's having your sniffer on. That's looking for that person who just doesn't quite look right, and they just seem to be ill, and you can't quite put your finger on it.
Yep.
All right. And then the last one is therapeutic drug levels needed. How would you possibly know which drugs require therapeutic drug levels? But it's mostly like cardiac medications, blood thinners required therapeutic drug levels, and then some seizure medications require drug levels. We, of course, don't expect you to have a running list in your mind of which drugs require therapeutic drug levels. Remember that you have access to resources if you have questions. You have a base hospital that is there to be your guide and to assist you and can walk you through some of these things. They may be wondering why you're calling them, and that may take a little bit of a conversation, but at least you can get through this. And so we've made it all the way through this. We don't have any identified medical concerns. We're not violent. We've made it through the S.M.A.R.T clearance. Next point, we would be engaging either the Mobile Integrated Health Unit, or potentially as the assess and refer policy becomes live, we may be able to find a way to get those patients directly to a psychiatric facility or behavioral health facility. I know that this conversation is going to create a lot of conversations for you. That's okay. That's okay. Remember, and just keep in your mind that there are a lot of exit points here. The idea is to exit from this and take them to an emergency department, rather than take the risk and take them to behavioral health. We do not want to have someone go to behavioral health facility that ends up having to have a delay in care of their medical condition. So that about wraps it up. I do want to finish with your typical patient. Having run a program like this in Stanislaus County and taken care of a couple thousand patients that the paramedics did use this S.M.A.R.T clearance algorithm, once you get used to using it, it becomes fairly easy. And your typical patient is going to probably be that patient that has mild psychosis, normal vital signs, knows that they have a mental health condition and needs help. Hearing voices, stopped taking their medications, lost their medications, and they just need help. Or it's going to be the person who's depressed, suicidal, has a plan, but hasn't taken any attempt to kill themselves, hasn't taken an overdose or anything. In Stanislaus County, the vast majority of those patients were those two populations. So if that gives you an easier way to look at this, those are the two most common patients we'll encounter, which there are a lot of them here in Sacramento County that we transport to the emergency department that will meet this clearance algorithm and be able to eventually get to a psychiatric facility. We expect that these numbers are going to go directly to psychiatric facilities. They're going to be pretty small because there's a bunch of things that happen under here that we haven't even talked about that'll happen later. So, Dr. Quist, thank you.
Absolutely, and thank you, because this is a great collaboration between Sacramento Behavioral Health and Metro Fire, and looking forward to continuing to improve the services for the folks in our communities.
Excellent. If you have any questions at all, please don't hesitate to reach out to me via email or Captain Perryman. We can answer your questions as well, and if we can't answer it, we've got great friends who in the behavioral health community that can help us answer it as well. We appreciate your time, and thanks for joining us.